everyone. Welcome to another week of Antidote Stories in Medicine. I am your host, Christine. It is great to have you guys back. I have been loving seeing all the new countries that have been popping up. It's so amazing, the idea that people are listening to this podcast all over the world. Still no Antarctica. We're working on it, but it hasn't happened yet. Thank you again for everyone that has been interacting in the Facebook group. It's really growing, and I love just talking to people and hearing your own little stories. Of course, thank you so much to everyone that has been leaving reviews. It's really funny. I can see when we make little blips on the charts, and it's always after you leave a review and there's a bunch of downloads, and it's like very fleeting, like at 3 a.m. we're on the charts. So I would like to be on there for a little bit longer than 3 a.m., but it's great. I'm so flattered that we're up there. It's really incredible. I just had no idea that the podcast would become this, and I'm so grateful for all of you guys that keep listening. So please just keep reaching out. I'm going to keep responding to you as much as I can and in any way that I can. And people have also been suggesting episode ideas or ideas for episodes. So please keep doing that. I really want to hear what you guys want to listen to. And people have been saying, hey, I've got a really cool story. Let's record. I'm totally down to do that. And we have really great episodes coming up because of that. So please just keep doing it. I'm so happy to be doing this and bring you another great story this week. So this week is actually an old friend of my sister's. She has been a nurse for several years now in an emergency room. So this week is Liz. Hi, Liz. How you doing?
I'm good. How are you, Christine? Thanks for having me on the podcast this week.
So Liz, you went right to school for nursing, kind of the more traditional route.
Yep. I went to nursing school straight from high school, did a traditional 4-year undergrad, and graduated with my nursing degree.
And what did you do out of nursing school? What was your first job?
Straight out of nursing school, I did med-surg. I did that for about 1.5 years. And then which is just like kind of more general inpatient. I worked at a big hospital. My floor focused on lung transplants.
Oh, okay.
And after like 1.5 years, I was a charge nurse. I was orienting new nurses, and I was ready for a change. And I decided to go into emergency nursing, and I've never looked back.
So what drew you to emergency medicine? Obviously, med-surg is hard, but it can be grinding.
I like that it's something different every day. It's a different diagnosis, a different patient. Like literally no 2 days are ever the same in emergency medicine.
Yeah, yes, that is very true. And it's pretty fast paced, which that's what I loved about it.
Yeah.
You can go from 0 to 60 and have no idea it's coming.
Oh, very, very quickly. Yeah.
And you work in a really big ER.
I do. I work at, it's about 70 beds. It's a level 1 trauma center. So we're the receiving facility for a bunch of the smaller community hospitals in the area that don't have certain services 24/7, like neurosurgery, the cath lab, the trauma team. So yeah, we're always getting patients even at 2 a.m. We're getting transfers from the smaller community hospitals.
Your hospital was one of the ones that we used to bring a lot of patients to when I worked on the ambulance.
Oh,
so
yeah.
We would do all of those transfers, the stat transfers,
yeah.
at 3 o'clock in the morning.
Oh, yeah.
When somebody had something really bad happen in the community hospital, didn't have a neurologist on staff or neurosurgeon.
Yeah.
Just, you kind of touched on it, but explain what a level 1 trauma center is compared to, level 2, level 3.
A level 1 trauma center, we have pretty much every service available to us 24/7. A lot of the smaller hospitals that we receive patients from don't even have neurosurgery, don't have a cath lab 24/7. We have to have those things available 24/7. So we always have a neurosurgeon on call. We always have a cardiologist on call. We always have a neurologist on call. You name the specialty, we always have someone there on call. Not even on call, they're there in the hospital.
Yeah, they're in the hospital.
Yeah.
And they're just capable to receive those patients at any time.
Absolutely, yep.
It's really impressive. And we mentioned that you work at a level 1 in Boston, and for many cities, that would be one hospital.
Yeah.
But Boston has multiple.
Yeah. So, and it's actually really interesting when we're getting traumas. It's like, how do they choose which hospital to go to? And I mean, the trauma transfers, my hospital or most of the hospitals in the area will affiliate within other hospitals. So there's like certain healthcare systems.
Yep.
But even when EMS is bringing you a patient, it's just kind of interesting. You're like, is this closest? Is this a patient preference? Like, how are they choosing to bring this patient here? Is it stability?
Yeah, that's actually what it is.
Yeah. Or it's a variety of all of the above.
Yeah. So I actually shed some light on that. So patient preference or closeness, we would pick hospitals that we liked too for EMS.
Yeah.
Depending on how stable they were. If they were really unstable, it was the closest facility, the closest appropriate facility. That's the big key word there. We're not going to a little community hospital. If we're having a stroke, they need to go to one of those big level 1 centers. But if it's a cardiac arrest, you have to go to the closest hospital, regardless of what it is, that has an emergency room. But yeah, if it's a really big trauma, but they're stable enough to have a decision, or there's actually 2 level 1s basically right next to each other in your area.
Yes.
Where you are.
Yes.
And when it comes to that, if the patient or their family can make a decision, they'll say, I want to go to hospital A or hospital B. And in EMS, we go, yeah, all right, whatever. And in Boston, you have that choice.
Yeah, there's like 5 huge level 1 trauma centers within like a 3-mile radius of each other in Boston.
And I think 3 pediatric level 1 ERs.
There are. That's actually one thing that's interesting to where I work, is that we don't have pediatrics. So sometimes people will bring their kids in and we'll be like, yeah, you're stable, but you need to go someplace else.
But the pediatric level 1 trauma centers for you is like literally across the street.
Literally across the street, yeah.
It's so funny that like, why would a parent choose your hospital when...
I think, so we do have labor and delivery there. So I think a lot of parents are like, oh, I delivered my baby here, so let me just take them back here. That's what I've noticed the most.
Yeah, that might be it. Yeah. I think so a good friend of mine delivered a child there, and the child had some pretty significant complications during birth and was immediately sent over to the other one. And the child did very, very well.
Good.
It would not have done well if they had not been in such a proximity to the amazing facilities that are in Boston.
We are very, very fortunate to have so many fantastic facilities in Boston.
I work in DC now, and it just kind of boggles my mind that there are not as many level 1 trauma centers.
I know. One of my former colleagues is now a travel nurse, and she was telling me that like it can take 2 hours to transport a patient from home to the nearest hospital. And that just boggles my mind.
Yeah. You get so spoiled working in Boston when you have all of these options. Yeah. And when you work in EMS, hospitals can go on divert for certain services. Like they don't have capability, like they won't have any more neurosurgical capabilities for certain traumas. Yep. And it's not as common as it used to be. Hospitals used to go on divert all the time. Like this is like 10 years ago or so. Now there's stricter rules about when they can do it. But, you know, if a hospital says, nope, we're on divert for this, they're on divert. You can't bring them there. Yeah. And in Boston, you go, okay, well, I'm going to pick the other 4 level 1 trauma centers. Yeah. So you have those choices. I mean, other places are like, well, what do I do? Yeah. You know, they're going to go someplace else. It's just, you're really privileged just to have so many great facilities there. Yeah. So what has it been like working in the ER? What have you really enjoyed about it? What have been the hard things? And so one of the things is just, it's rewarding, but it's interesting. I work at a teaching hospital. So we start off with brand new doctors straight out of med school. And I hate to say they don't know anything, but they say, hey, I'm a doctor. I'm brand new. And like, I'm going to order all these fancy tests. And, you know, I've been there 4 years now. And I kind of scratch my head. And I'm like, why do we need this? So it's really rewarding to watch the doctors grow and develop over their residency and then become attendings. Yeah. I had an interesting case a couple of months ago where I was working with an intern, and he was just like, he was very, very convinced like we could do. So my patient needed an MRI, and she was in a lot of pain, and she wasn't going to be able to lay still for it. And I said to the doctor, I was like, we're going to need to intubate this patient in order to successfully get the MRI to keep her still. And he was like, oh, no, let's just give her some more morphine. And I was like, so she's gotten a boatload of morphine at this point. Like, I would be needing Narcan at this point. Yeah. And he was like, no, it's fine. I'm like, no, it's not to say it's not fine, but like, this isn't working. More drugs are not the solution. Right. For anyone that doesn't know, MRIs they're magnetic resonance imaging, and you have to lay very, very, very still to get a clear picture on the MRI. They're not very forgiving when it comes to movement. Yeah. So why are you going to torture this poor woman going through an MRI to get a bad picture you can't really use? Absolutely. So finally, not even finally, after like an hour, the doctor was like, okay, fine. No more morphine. Let's try. I don't even remember. He was like, let's try some fentanyl, which is a little bit stronger. I was like, yeah, fentanyl is a great drug, but it's not going to last as long. Like, it's still not the solution. Like, we need to literally like put this patient in a medically induced coma to keep her perfectly still to get this MRI. Yeah. And it was like, the doctor was like, no, it's fine. Let's just give her the fentanyl and send her down. So we did. And literally, she wasn't even at MRI for 10 minutes before they called me and were like, yeah, she needs to come back. You guys need to figure something out.
So when she came back, I touched base with the doctor. I was like, this isn't working. Like, and he was like, okay, well, let's try another stronger drug. Let's try some ketamine. And I was like, okay, like, and ketamine actually is a great drug. I don't know if you want to talk about it, but like, it works really well for pain control.
Mm-hmm. Yeah,
but it's not one that we use very often in the emergency room. So I was like, I've seen it work really well, but I'm not familiar with the dosing and the this and the that. Like, so I was like, all right, like we can try that. So we give it and it doesn't really work. She's, 20 minutes later, she was still complaining of the pain. So finally, after like an hour, I was like, nothing is happening. And finally he was like, all right, like, do you want to intubate so that we can lay her still to get this? And I was like, yes, I do. Like, I've been saying this for hours.
And she's already had half the drugs you would give her for an RSI or a rapid sequence intubation induction anyways. And do you mind me asking what her injuries are?
Yeah, so she, part of the issue with this particular patient is that she had a history of drug use, of IV drug use, and we need to get an MRI to rule out an epidural abscess. She had, they were concerned that she might have had like a spinal infection. Mm-hmm. And the patient told me she shoots up heroin. Like, giving her fentanyl is not the solution.
Right, because she has probably a really high tolerance.
Exactly.
And that also brings up a great point of she's got a really high tolerance, but we still need to treat her pain. It doesn't matter what kind of substance use history someone has. You still need to provide them with excellent medical care and adequately treat their pain. And there's also a lot of studies that show that substance users, especially opioid users, have heightened responses to pain.
Oh, yeah.
So kind of this, like, we don't know if that they have heightened responses to pain and that makes them abuse opioids, or the abuse of opioids causes them to heightens their pain.
Yeah.
So either way, you have to manage their pain, especially if you have an abscess in your brain.
Yeah.
That's not comfortable.
No. So finally, it was probably like 2 or 3 hours of me, I don't want to say I was arguing with the doctor, but I was just, if she has this abscess, like that's something that's very, very urgent, and we weren't going to get a good quality image otherwise. So finally, after hours of saying like, we need to do this in order to get the patient comfortable, to get the best quality image, we finally decided to intubate. So we pushed the RSI drugs, we intubated, and one of the things we do after we intubate is we give post-sedation medications.
Right.
And I had asked them, what drugs do you want? Normally we'll use propofol. Sometimes we'll use fentanyl and Versed.
Yeah.
And they said, oh, let's do propofol. And I was like, that's fine, but I'm worried she's going to become hypotensive because propofol is known to lower the blood pressure. Yep. And they're like, oh, no, it'll be fine. You have lots of room on her blood pressure. And her blood pressure was like in the 150s.
Okay, yeah.
But I was like, again, this is a woman with a very high tolerance. I think I'm going to require higher doses of medications to keep her comfortable.
Right.
So I started the propofol drip. I upped it. I started it higher than I would have, and she is bug-eyed, trying to reach for the tube to pull it out of her mouth. So I upped the rate, and finally I got her comfortable. And of course, she's now has a blood pressure in the 70s.
Oh, no. And you have the orders are written so that you're allowed to titrate to effect.
I am, yes.
I don't think people realize that nurses can do that you are adjusting the dosing.
Oh, yeah. A lot of things are like, we have the ability to titrate our medication, or some of the drips, we have the ability to titrate to a desired effect, whether we're titrating vasoactive medications to keep a blood pressure where we want it, or titrating sedation to keep them at a level of comfort. Yeah, we do have that ability.
These are obviously very dangerous medications because you're lowering her blood pressure pretty significantly. I mean, propofol is pretty dangerous if you mess it up.
Yeah.
So her blood pressure went to 70 systolic, which is the top number. What happened then?
We started some fluids. I talked to the doctor, and we decided to change the sedation, which I think was the appropriate thing. After some fluids and changing the sedation, her blood pressure normalized, was right back in the 120s, right where we wanted it. But it was very frustrating because I was like, I foresaw this happening. And They were like, oh, no, it's totally fine. And I'm not at all trying to bash doctors, because they're every 100% part of the team. And I love them. I love working with them.
And this was an intern?
It was an intern, yeah.
So this is the first year out of medical school?
Yeah.
Okay. And this was a few months ago, so this was probably July-ish?
Yeah. Shortly after July.
July is the beginning of the medical year, so they just graduated. This is like the first few months of the job for a brand new doctor. So
this is a very sick patient for a brand new doctor.
Yeah, I mean, everybody learns. I mean, I definitely have made mistakes new in my career, but this is why you listen to nurses.
Yeah. So needless to say, we got her intubated, we got her pain control, we got her to MRI, and she actually did not end up having the abscess they were worried about.
Oh, that's good.
But once we got her up to the ICU, it was because she still had the breathing tube in, she was admitted to the ICU just kind of for further management. I think she was very quickly had the breathing tube taken out. But the doctor was like, "Wow, how did you know all of that was going to happen?" And I was just like, "I've done this a long time. I've seen this sort of stuff happen." And so it was rewarding to kind of, I shouldn't say it was rewarding, but like it was just funny because the doctor was like very, very confident in like, "Oh no, I think this is all best." And I was like, "Are you sure?" And for him to be like, "Oh wow, like yeah, like this didn't go as I planned."
It is nice to have that reflection and the recognition that he had a learning moment after working with you.
Yeah. And I mean, and like very fortunately, like everything turned out okay for the patient. Like there was, as far as I'm aware from the follow-up that I have, like the patient was discharged a couple of days later. She didn't end up having that abscess. She did have an infection that she was treated with antibiotics and was able to be discharged. So like everything turned out okay.
I don't think people realize, I know people don't realize what nurses do behind the scenes.
No.
They don't know that the nurses are behind there advocating for them constantly.
Yeah.
When treatment decisions are being made.
It's one of the things that I actually really like about where I work is that as a nurse, I have a lot of autonomy. And the reality is we're a very busy hospital. Patients have had to wait. I've seen patients waiting up to 6 hours from the time they check in to the time they're moved to a room.
Yeah.
And that isn't even how long it takes the physician to actually see them once they're moved to a room.
Right.
But one of the things that's really great about where I work is that we really do have great communication with our physicians. And when I'm working in triage, as patients are coming in, if I'm concerned about certain things, I can order some labs. I can order certain diagnostic imaging. So, if I'm in triage and a patient says, "Oh, I'm coming in with the worst headache of my life," as long as I just kind of run it by a physician and say, "Hey, I'm concerned that they might have a subdural hematoma," because when a patient says, "I have the worst headache of my life," that's usually a precursor to a big head bleed.
Right.
So, if I say, "Hey, they look okay, but they're complaining of this," and, maybe they're a little pale, but their vitals are okay, their pupils are still reactive, they're still alert, but, do you mind if I just order that CAT scan? And it's usually, yeah, that's fine. Or, we can order labs. If the patient says, "Oh, I'm just feeling really weak, I haven't been feeling myself," I can order labs, and lo and behold, their hematocrit is 20, and you're like, "Oh yeah, you need a blood transfusion. That's why you feel so weak."
Yeah.
So it's nice that we do have that autonomy to be able to order things just while they're waiting so that we can kind of get the ball rolling for the patient.
And the patient feels more satisfied because they feel like something is being done, even though they're waiting.
Yeah. One of the things that I think people don't necessarily realize, though, is like, not to say why they're waiting, but when I work in triage, people will feel very frustrated sometimes when they're waiting and they see other patients going straight back.
Right.
I was recently in triage and we had a trauma that did go straight back. It was the patient had fallen several feet. They met the trauma criteria. They went straight back to the trauma bay. And my patient's sister, I believe it was her sister who was with her, came up to me at the nurse's station and was like, "Excuse me, how come these other patients are going back before her? In terms of pain," what did she say? She was like, "With the exception of one other patient, no one appears to be in as much pain as my sister." And it was just really interesting. I was like, wow, not to say you think that you're going back just based on your pain, but like, we're looking at your vital signs. We're looking at the mechanism. Like, why are you here? Is this something that's, what we call a fast track? Do you just need stitches or like an x-ray to rule out a broken bone in your ankle that you might have rolled playing sports? Or are you hemodynamically unstable? We're looking at that. Yes, of course, pain is a very important factor, but we're looking at a bigger picture.
Yeah, I don't think people understand that. And they don't. And it's our place to educate them as professionals. But people don't want to hear it because they're in pain. They're uncomfortable.
Exactly. Yeah, they're uncomfortable. And I get it. It's no fun to be in pain. No one likes to be in pain. But it's, you have to treat the life-threatening injuries first.
And also, it's really hard for them to rationalize why someone's going back before them when they can't see these really critical injuries. Like, you can't see a heart attack, but you can see a broken bone. And
exactly,
to be completely honest, a broken bone is not as critical as a heart attack. Like, you can have a broken bone for a couple hours and not die. You can't have a heart attack for a couple hours and not die.
Absolutely. Absolutely. Yeah.
And especially with certain patients, you can't tell that they're having a heart attack unless you're doing an EKG and you look at them and you go, "Oh shit."
Yeah, definitely.
People love to question your judgment all the time.
Oh, all the time. I recently had a patient who, when she came in, she was just telling me that she had felt like I forget. Oh God, I can't even remember what her complaint was. That she was just feeling like she was young. She was probably my age, so in her like late 20s, and she was just feeling like tired, low energy, and maybe some like abdominal pain. No past medical history, like young, healthy 20 some odd year old. And after about 20 minutes, she came back to me and was like, I'm feeling really short of breath. I'm just really not feeling good. And I was like, all right, well, we have like a set criteria for someone we would get an EKG with. And someone, a 20-year-old with no history, who's just saying she's having some belly pain, is not someone I'm concerned I'm going to be getting an urgent EKG on.
Right.
So, but the fact that she came back, it's not super busy to get an EKG. So it's like, why don't we just get an EKG just to kind of make you feel better, like make you feel like we're doing something.
Right.
And she got really upset. She was like, why didn't you do this earlier? And I was like, you didn't say anything to warrant me to feel concerned enough to get an EKG.
Yeah.
And she was like, well, I was feeling short of breath. And I said, you never told me that. And she was like, well, you didn't ask. And it was just like, no, I didn't. But when I asked you why you're here, you never said you were feeling short of breath. And I think people think that I can sometimes read their mind. I'm like, no, I didn't know you were feeling short of breath. I'm sorry. Like, let's get the EKG now then. Like,
yeah.
I don't know. It was weird. I was like, sorry, I didn't know you were so short of breath.
Yeah.
Because like you're not exhibiting, like you don't have a history of asthma. Your breathing pattern is normal. You don't sound wheezy. You're speaking in full sentences. Your oxygen saturation is great. Like there was no indicator to me to be like, oh, are you short of breath? And truth be told, she was like nothing ended up happening. She was fine. She was discharged. She did not have any respiratory illness. But
yeah, you sometimes ask questions based on you always ask questions based on your physical exam, but if there's nothing in the physical exam that points to it, you wouldn't ask questions necessarily that aren't pertinent because you're pressed for time. It's a busy ER, it's always past pertinent history.
And that's triage is where we're trying to figure out the life-threatening injuries, like how sick or not sick are you?
Yeah.
And then based on that, can she wait or not? Yeah, she could wait. She went back I had her take a seat in the waiting room, and then she ended up going back probably 20 minutes after she got to the emergency room anyway. Like it wasn't like it was a very long wait that day. But, my decision at that moment was, are you sick or are you not sick? And she's not one of the ones that is life-threatening sick. So she didn't get an EKG. She didn't I didn't ask more leading questions. Are you short of breath? Are you having chest pain? Typically that's the assessment that we do when the patient is in the room.
Yes. You do more detailed assessment in the room. Triage is just like, the bare.
Why are you here? Oh,
bare bone.
Bare minimum. Yeah. Why are you here? Okay.
Great. People just don't understand the differences. It's so funny. My sister, we took my niece to the emergency room after she whacked her head on a table at the airport.
Oh.
Yeah, she's fine. But she got some staples in her head. And then the next morning she started vomiting. And she got her bell rung pretty good. And so I said, all right, well, she'd already got the staples, but now she's vomiting, and she vomited several times, and she was just out of it. So I said, let's go to the children's hospital. And my sister is not medical at all. Mm-hmm. She's very sweet, not medical. And she's like, well, let's go to the local ER. I'm like, well, they don't have a peds section, so that's not appropriate. We need to go to the pediatric big hospital because I don't want someone doing a CAT scan on a 4-year-old because they don't know what they're doing. Mm-hmm. You don't want to expose a little kid like that to radiation. If she needs one to rule out a brain bleed, sure, but I want that decision made by a provider that sees kids with concussions all the time. I don't see kids with concussions all the time. I wouldn't make that decision. But I don't want her going to the local ER that doesn't have a peds section.
And I think that's one thing that people don't like. They'll go to their nearest hospital, which is sometimes fine. But and I think that sort of comes back to me working at a level 1 trauma center, that we have certain services available to us 24/7. So that's part of the reason that I think my hospital is so busy, because we have those specialties that other hospitals don't have.
Yeah.
We don't have peds though.
Yeah, you don't have peds. So we get there. The registration lady is the first person you see in line, and the woman, what's your name and everything. And my sister she's a business lady. Oh, that's such an 80s term. She owns her own business. So she's very organized, and she's very, very sweet, but very intense. And the registration lady goes, "Why is she here?" And my sister just without like, she takes a big deep breath and she starts to go, "Well, we were at the airport and she hit her head and she had these staples and she goes the whole thing." And she said, "Go, go, 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 go." And I go, "Head injury. Like, this is the registration lady. You don't need to tell her the whole story. We're going to tell a brief story to the triage nurse at the front desk, and then we'll tell more of the story to the triage nurse in the little room, and then we'll tell more of the story when we get back to a bigger room in the back."
Yeah.
My sister was like, "What? What do you mean? I don't tell everyone my life story?" And I'm like, "No, we don't. Calm down. She's okay. She's watching TV. Like,
Yeah.
we can wait. She hasn't thrown up in a bit."
Yeah.
But it was just kind of funny to see that and realize, oh yeah, even my very, very well-educated sister, she just, it's your own kid and you don't know, and you're not.
Yeah, she must have been terrified about her daughter.
Oh yeah, and I totally, and when I have patients like that, I try and understand that, and I try and educate them that this is how this process is going to work, and when you go here, you'll do this and you'll do that. And when I worked in EMS, I tried to explain that to you. First we're going to see the triage nurse. I'm going to tell them a little bit about why you're here. We're going to get you into a bed. When you get into the bed, the nurses are going to come in and get more of your story and talk to you. This is what you can expect, because that helps with people's fear. And then they know when, you may wait here. And the more you can tell people about the process, the better. Because if they're not used to, we do this all the time. We know what to expect. It's easy for us.
Yeah. One thing that I think I've learned as an emergency nurse is that one of the techs that I work with, so just someone who works in the department, she asked me, she was like, "Do you ever get stressed?" I was like, "Yeah, of course." She's like, "I've never seen you stressed here." And I think the thing that I realized was like, it's not my emergency. It's not my time or place to get stressed. Like,
yes.
If I got stressed out during a cardiac arrest or during whatever, I wouldn't be functional in my job. Like,
no.
I would be like, "Oh my God, someone's dying. Like, what do I do? What do I do?" I would not be, I would be more of a problem than I am a solution. Like,
yeah. I think I'm better at stressful moments than I am at like regular moments.
Yeah, I actually agree. Like, I mean, sure, I think we're human. We all get stressed, but just what stresses me out is not what stresses other people out.
Oh,
so
yeah.
I think when family members are like, "Well, what do you mean you don't need my whole life story?" It's, you're just kind of like, "Nope, like, let me try to reassure you, let me help you out, and let me just try to do what I can do to make your day a little bit better."
Yeah, like I'm so much calmer when there's a cardiac arrest or there's something crazy happening in front of me, or there's some massive uncontrolled bleeding that I'm trying to stop. I totally have emergency voice.
Yeah.
Totally have it, totally go into this demeanor. Now, there's a lot of laundry to do and dishes and my house is dirty. Oh my God, stressed out mess.
I'm going on vacation on Monday. I still need to pack.
But otherwise,
before. Yeah.
It's
throw a cardiac arrest in front of me, no big deal.
Yeah. So my niece, like, I had come over to check her out after she hit her head, and I was like, "Oh yeah, she's fine, whatever." And then she throws up, and then she throws up on top, like onto me. And my sister's like, "Oh my God." And then all of a sudden, like, I didn't even realize it, but my boyfriend was there and kind of called me out on it. And he goes, "Your voice changed." And I was like, "Oh yeah, emergency Christine kicked in." It was like, "This is okay. Let's just clean her up, and we're going to get her in the car, and we're going to go to the emergency room now."
Yeah.
Like, "I haven't even showered." I go, "That's fine. Just put on some clothes. We should leave now, though." "Should I call 911? No, that's okay. But we would like to go now." But I can't do laundry.
Yeah, no, me neither. It is funny too, especially like when your family calls you and they're like, "What do I do? What do I do?" Like, my sister called me like a month ago and she's like, "I was washing dishes and I didn't realize there was a knife at the bottom of the sink and I stabbed myself and it's bleeding. What do I do?" I was like, "Well, like, how bad is it? Like, how deep is it?" Like, she's like, "Do I need to get stitches?" And so as she's freaking out, I'm like, "You're fine. Wash it out, put a Band-Aid on it, hold some pressure. Like, how deep is it? Yeah, you might need to go get some stitches."
Yeah. Go within 6 hours.
Yeah, but she was so panicked. I was like, "You just need a few stitches, no big deal."
I definitely think I downplay things, especially with family. I'm like, "You're fine, whatever."
Yeah.
If and when I ever have children, I'm totally going to be that person of like, "Yeah, walk it off. You'll be fine."
Yes, I am too. My boyfriend and I talk about that all the time. And I was just like, our kids are going to be so screwed someday because they'll probably have like a broken wrist for 3 days. And I'll be like, "Oh, you're fine. You're fine." And then finally they'll convince him to take them to the doctor and they'll be like, suspect me of child abuse.
It was, when I first moved into this apartment down here, or first moved in with my boyfriend, his cleaning style is different than mine. We'll say that. He broke a glass, and he decided that like just sweeping it up a little bit was fine, and not like vacuuming up all the glass shards. And so I was like standing barefoot in the kitchen, and a huge shard of glass like went into my foot, and it was just stuck in there, and it was just bleeding everywhere. And I was like, oh my God, this. And I was like, I am not going to an urgent care for this nonsense. I was so pissed off. So I do house calls and stuff. And so I was like, get my bag. He works with cybersecurity and IT stuff and not medical at all. So I was like, you're going to help me. This is your punishment. You don't like blood, but you're helping me. And get your gloves on. That's how you put them on. Give me my stuff. I'm cleaning this. I'm numbing my own foot up, and I'm removing glass from my own foot on the kitchen floor because I am not going to the emergency room.
Yeah.
I don't want to do it. This is ridiculous.
Yeah, no, I remember actually I had to go to the ER as a patient, and I was like, I sat around for like 3 hours just trying to decide, do I go? Do I not go? Do I go where I work where they're going to know me? Like,
oh yeah. Yeah.
Like, oh, it was terrifying. And when I got there, so I ended up having a ruptured ovarian cyst.
Oh no.
So I was bleeding, and I was just like, I was mortified because it was a GYN issue. I was like, someone's gonna have to do a pelvic. Like, I got there, I had my heart rate was like in the 130s. I was so pale, and by the time I had stopped bleeding, I lost 40% of my blood.
Oh my gosh! And did you go to your own ER?
I ended up going to my own ER, but like that was literally like I probably sat around for 2 hours being like, I'm dizzy, I'm lightheaded, I'm bleeding really profusely. What do I do? I'm like, of course I know I have to go to the ER. If anyone were to ask me that, I would tell them to go to the ER. But I was like, no, I'm fine. I just don't want to go. And then once I made the decision, I was like, where do I go? I don't know if I want to go to where I work.
But I don't trust anyone else. I know they're good.
Well, and that's the reality. I was like, I do trust them, and it's such a good feeling actually. Like as soon as I got there, they got me right back. My manager came down to see me, which was very embarrassing. But ultimately, she's like, you're not coming into work tonight. I was like, okay,
we'll give you some blood and a night off.
Yeah, right.
So I guess we're talking about our own personal emergency stories. When I moved down here, so embarrassing stories. I had from moving down here, and you drive a lot. I drive a lot to come down here. It's a long trip, and somehow developed a pilonidal cyst.
Ooh.
Which is so super embarrassing confession. So pilonidal cysts are basically there's like layers of skin, and they're in your coccyx. So basically on your tailbone from like sitting for long periods of time. So driving back and forth from Boston to DC to like interview and like visit my sister and stuff, you just develop them, and they can be huge and they can get really infected. And so my first week of work, I had developed this pilonidal cyst that was probably the size of like a tennis ball.
Oh,
yep. It was so painful. And of course, my old health insurance had run out. My new health insurance wasn't kicking in yet. And I'm like trying to sit at my new job where I just met everyone in this super small office, like really awkwardly because you can't sit down.
Yeah.
And I wasn't telling anyone. I was living with my sister, so I wasn't even like in my own house. It was the most painful thing I have ever had in my life. So what do you do with infected cysts? You have to get them drained.
Yeah.
And, oh my God. So I went to an urgent care. They tried to drain it. They couldn't. And then I didn't tell anyone about this. And then I still kept going to work with this.
Oh my God.
And then they put me on Augmentin because it was infected. It got like this surrounding cellulitis that got a little bit worse.
Oh my God.
Then it was like finally really needed to be drained. And so I walked into work one day and I told my boss, who was a doctor, who I literally just started working for 4 days before. And I was like, I have an infected pilonidal cyst and I'm really febrile and I'm shaking and I'm in so much pain. I think I need to go to an emergency room, but I don't know where any are. And I know there's bad ones, but I don't know which ones they are. And he's like, okay, well, you should go to the one that's really good. And it's 5 minutes down the road. It's right around that big circle. And I'm like, I don't even know where that is. So I go to the emergency room. I get there. And of course I have to drive there, which is painful. And then thankfully it was like 7:00 in the morning because that's when I started. No one was there. They took me right back in. They're like, "Oh yeah, we know your boss," and I'm like, "Yep, great. Everybody knows my boss."
Yep.
They're like, "Who's your primary care?" I'm like, "I don't have one because I just moved here."
Because you just moved. Yeah.
And so the attending goes, "Oh, where'd you move from?" "Boston." "Oh, I did my residency there." We knew the same people. I was like, yes, medicine's a really small world. I worked for this ambulance company up in Boston that used to contract there. And he's like, "Oh, I know all these people that worked there. And I knew your medical director." And I was like, yeah, great. Fantastic.
Yeah.
So giant cyst on the coccyx needs to get drained. Thankfully, they medicated me.
Oh, thank God. Yeah.
Thank you, God. There is a use for pain medication in certain circumstances. I will tell you, this was it. And so he has scribes with him.
Oh.
And he goes, "Do you mind if the scribes watch? They want to go to medical school. This is why they're getting experience, and this would be really cool for them." And you know what? I've been there. I've totally been that student that's like,
yeah,
I want
to see this.
I want to see this. And you know what? Getting cysts drained, it's really cool to do. I love doing it.
It's very gratifying to watch.
And it's so gratifying to watch. And so I was like, yeah, of course. And so there's like 3 scribes that are standing in the room with like, everybody can see my butt. And this guy drains this cyst on my coccyx. And it was huge. And they're like, "That's so cool." And I was like, yay, education.
Right? Oh.
They're like, "Thank you so much." And the doc was like, "Yeah, I figured you wouldn't mind." And I'm like, "No, whatever. Just
yeah, you took care of my problem, whatever."
Like, I got a day off of work and
yeah.
But yeah, you're just like, you totally put things off. I probably, if I had gotten it taken care of like a week beforehand, probably would not have had to get it drained. Probably would not have been that bad. But I was like, no, this is fine. I don't need this.
Yeah.
And now this is going to be on my podcast with this totally embarrassing story, but
whatever.
Yeah. Anyways.
I don't know. I think it's just as bad showing up to your ER saying, "I'm bleeding from my vagina for the last 6 hours." And yeah.
Yeah. Please do a pelvic on me.
Yeah.
Any more interesting ER stories? Anything that's been really challenging, or what's kind of one of the biggest adrenaline rushes you've had in the ER?
So I love like a good trauma, and I hate to hate to say that, and like I hate to say that, like, oh, people are really sick, but like,
no, I get it.
We recently had, and of course, I mean, 7:00 a shift change. Literally at 6:55, the radio went off saying, "Hey, this is whatever ambulance. We're 5 minutes out with a 65-year-old woman. She was hit by a high-speed car while she was trying to cross the road. She is, we can't get a blood pressure on her. She was intubated in the field." And so, of course, I've worked all night, and I hear that radio, and I am like, you get into like go mode, we're getting ready. Go mode. We're getting ready to the rapid fluid infuser. We're getting blood ready. We're getting ready to put in big IVs. And when she gets there, I mean, she was sick, and like literally as we're getting there, and it's funny because the night team who was getting ready to go, we heard the radio report as the day team is coming on. So now there's so many people in the room.
Everybody wants to play.
All there were, it's all hands on deck. It was kind of it was a really well run trauma because there were so many people there. And I mean, like the traumas are normally very well staffed, but there was so many extra people there that like everything was just so seamless. Like we ran the trauma quickly. We got IVs in her. We got her blood because she was very hypotensive. We got her to imaging. She ended up having a broken pelvis, which is why she was so hypotensive. We got her up to the OR. It was such a like everything went so well and so smoothly that morning.
Yeah, I love those big traumas. And it's, again, I don't love them because I feel really terrible for the patients.
Oh, absolutely.
But it's like the adrenaline rush, you can't beat it. Like you talk about that radio call, like being the one making that radio call. You're like flying across like a big bridge in Boston coming in, and it's like middle of the night. It's an adrenaline rush.
I remember there was one morning that we heard the radio call go off, and when you give, and you probably can attest to this better than me, but when you give the radio call, it's like you're telling us like the age and the sex of the patient, like their
mechanism of injury, what you've done.
Yeah, I feel like they gave us like the patient's vital signs first, and it was fine. And then they get to the point, oh, the patient was run over by a train and has a partial amputation of their leg. And we're just like, what? Like, was not expecting that when the radio went off. It's the same sort of adrenaline. We're all just like, all right, let's get ready, activate the trauma team.
Yeah, I used to usually call it in with like, and this is totally an example, it would be like 45-year-old female, trauma alert.
Yep.
So you knew it was a trauma first.
Yep.
Struck by a train, then unresponsive, amputation, vitals are this.
Yeah.
Intubated, ACLS protocols.
Yeah.
Etc.
Yeah.
Be there in 5.
Exactly. Yeah. Or actually, I mean, one of the really funny things too about Boston is that a lot of things are so close. Some of the traumas, again, depending on the mechanism, they'll drive from 20 minutes away because they recognize that we're the better facility to take them to than the closer hospital.
Right.
But like we had an EMS brought us a patient that they said like cardiac arrest, we're actually pulling into your driveway right now just because of how close everything is in Boston. By the time they were able to move that patient to radio us in, they were already there just because everything's so close.
Yeah.
Well, we'll be ready. We'll see you in 2 seconds.
Well, sometimes also when it comes to CMED, you have to hail CMED first on CMED 4. Then CMED says, okay, you wait. And then CMED calls up the hospital. So CMED will go, okay, change channel 7, CMED calling BI.
Yeah.
Stand by, rings you up. They ring you up.
And then I say, landline, go ahead.
Right. And so that may have been 5 minutes. So that transport time is gone. And they're like, yep, we're in your parking lot.
Yeah. Actually, my favorite too is when, as they're on the radio, you can just hear the beep, beep as they're backing up into the ambulance bay.
Yeah.
I see you.
Yeah. Sometimes when it was really crazy, I would hail CMED on the main channel and just be like, CMED, can you drop me a note? Because I don't have time for this.
Yeah.
And usually that was if there was like a combative patient in the back,
mm-hmm.
and CMED would hear someone in the background going, wah!
Yeah.
And they're like, yeah, we got it. We'll call him for you.
Yeah.
I'm like, great.
Yeah.
Age, sex, combative patient.
Combative will be there soon. Have security present.
Yeah.
But I mean, I think you probably get this too. Honestly, at this point, like so little things faze me. Like I just feel like I've seen it all that I'm just like, okay, yeah, whatever.
Yeah. And when something comes in that's abnormal and you're like, oh, I'm impressed.
Yeah. So actually, believe it or not, one of the things that I just recently had that was, and not that it's that normal or abnormal, but it was probably one of the sickest patients I've had in a while. But it's a really sweet guy. He is on Coumadin, which is a blood thinning medication.
Mm-hmm.
And he had some dental work. And somehow, some way, he ended up with a posterior nosebleed.
Mm-hmm.
So nosebleeds can be anterior or posterior. Anterior ones, you can typically like put pressure on your nose and it'll stop the bleeding.
Mm-hmm.
And the posterior ones are the ones that like drip down your throat. There's concern for airway. And this guy was like, I feel like I'm swallowing the blood. He then starts coughing up these big, huge blood clots. Like we ended up intubating him for his airway protection. But like I was in there probably every 10 minutes suctioning giant clots out of him. Like I literally ended up filling an entire suction container of blood from this guy's nosebleed.
Oh my gosh.
I was like, we need to do something just to secure this airway because he keeps coughing up this blood.
Yeah, that's not good for your stomach.
No, and like
or your lungs or anything.
Yeah, but like, and it was interesting because like he came in like, hey, my nose is bleeding, and like seemingly well-appearing guy. Yes, of course, obviously he's on a blood thinner and has a nosebleed, so that's concerning. But I was like, wow, I'm like, this turned around really quickly.
Yeah, this was not what I expected.
Yeah, I was like, oh, I thought we were gonna like put in a Rhino rocket, send you home. I was like, this did not go as expected.
That reminds me of a patient I actually brought to your facility many, many years ago, and this older middle-aged gentleman, he called 911. He was like, oh, I was coughing up blood. And you're like, all right, well, fine. That's like urgent, but not like really an emergency. But like, we'll bring you to the emergency room. And so we were kind of far away from your facility, mm-hmm. and he requested you guys. There was other level ones in between you mm-hmm. and us. So we're like, yeah, cool. We'll go to you. And he had like some bloody tissues with him. So I was like, okay, yeah, definitely concerning. Like whenever someone's coughing up blood, you think of, a malignancy or a really severe infection, or maybe they just have a really bad nosebleed and they're coughing and things are really dry and they're just actually coughing up from their nose and not their lungs. But whatever, still needs to get checked out.
Yeah.
Vitals were pretty stable, although his heart rate was a little bit quick, not bad. And all of a sudden, as we're in Boston, he's like, I'm going to be sick and vomit. He vomits up an entire emesis bag full of blood.
Oh.
Bright red blood.
Yeah.
So bright red blood, it has not touched the acid of the stomach yet. So it's probably from the esophagus.
Yep.
And an emesis bag, like those vomit bags,
those are big. That's like
a liter.
A liter? Yeah.
And then he did it 2 more times.
Oh boy.
And then his blood pressure started dropping. And we had not called a note into you guys because your facility is so busy. You only call in notes when it's really significant.
Yeah.
So we're like, oh shit, step it up, call in a note now. And we were like right there, and it ended up being a trauma note. And we're like, we have all of this blood in bags. Because we're like, what are we doing with this in an ambulance? 3 emesis bags full of blood. This guy just, and he looked at me and goes, do you think it was something I ate? And I was like, no, I do not.
Maybe, did you drink, end up with the varices?
I think it was probably an esophageal varices, which is a rupturing of a blood vessel in the
esophagus.
Yeah. Your trauma team was very impressed.
Oh, I bet.
Yeah.
Yeah.
And they're like, why didn't you call us sooner? And I was like, well, he wasn't doing this earlier.
And that's one thing that's crazy about emergency medicine is like people can flip in the blink of an eye.
Yeah. Oh, yeah. And you don't generally get that in primary care. You definitely can get the things that walk in and you're like, oh, that is not what we expected at all. But you get more of the chronic, you get the hidden things that you find. You find a lot of like cancers and stuff that people didn't know about that you do find. And that's exciting. And again, not exciting as in I enjoy it because I don't want people to suffer.
But you're figuring out why they're not feeling well.
Right. I enjoy the process of figuring out what's wrong with someone. I enjoy that kind of intellectual pursuit and problem solving. We find a lot of those and that hidden, like what is causing the disease process. We do a lot of that.
Yeah.
We find that, but nothing like all of a sudden we find an esophageal varices or something.
Exactly. Yeah.
Whoa. Crazy.
But I mean, a lot of what we do too is like, we don't see that every day either.
Right. Even in a big hospital like that.
Yeah. Yes. Actually, just yesterday, I had a patient he'd come in with like intermittent chest pain. And so we always get an EKG whenever a patient says they're having chest pain. His EKG was normal. We did labs on him and his troponin was negative. The troponin is a cardiac enzyme that's released from the heart when you're having a heart attack. And as he was, we'd like to do them like what we call serially. So we usually do them every like 4 to 6 hours. He was like at like 3.5 hours. She was just like, no, like my chest pain is back. And it's like, it's crushing. We're like, and like, he was like starting to get pale, a little sweaty. We're like, you don't look so great. Let's just get another EKG right now. So we got the EKG and it was showing ST elevations.
Which is a heart attack.
Exactly. So we contacted cardiology and literally the cardiologist was looking at the first one from 3.5 hours prior and the second one that we had just done. And he was like, I don't think I've ever seen a patient like actively having a heart attack, like an evolving heart attack right in front of me in the ER. Like, he was like, that was impressive.
And this is a cardiologist at a world-renowned hospital that's impressed.
Yeah, exactly.
And he probably went right to the cath lab.
We brought him right up. And I mean, this was yesterday at like 5:00. So I don't actually know how he turned out, but I'm sure like he was in the right place at the right time.
Yeah, that's good luck.
Yeah.
That is a patient paying attention to their symptoms, unlike you and I.
Oh, yeah. But I'm like, no, I'm fine. Don't mind me with my hematocrit at 24.
And dropping.
Yeah. The worst thing about it is that I was actually supposed to run a marathon like 10 days later.
Oh, no.
And so I was like, no, I can't be sick. So when I was there, I was like, oh, we always transfuse anyone whose hematocrit's under 25. And the doctor was like, oh, no, like you're young, you're healthy, you're going to bounce right back. And I was like, I'm supposed to run a marathon. Like, can we do anything? And they're like, no. They're like, I think it's better that you don't. And I was like, oh. But the reality is like, that's what they would tell any patient. And I'm like, but I don't want to listen. I never take my own medical advice.
Right. Most patients just want some IV fluids. You want some blood.
Yeah.
Give me your blood.
Yes, please and thank you. I'm A positive.
Well, thank you so much for taking the time. I mean, do you have any other stories or?
I mean, I could probably go on for hours, but I think the listeners are probably getting bored.
Well, I know. I think we could probably just keep going back and forth. And this is always what happens. People are like, I don't think I have really anything to talk about. And I'm like, Just wait. I think we'll be
Oh, yes, you do. Yeah, I said that at the beginning. I was like, what do you want to talk about? I don't have any like stories that stick out in my mind as like, ooh, this patient or that patient.
Yeah. No, it's medics war story time. That's what happens.
Yeah.
Everyone is like, that reminds me of this thing. Yeah. Everyone says the exact same thing. And it's like, nope, we got stories for days. And the problem is like I tell stories and then I edit them out because like sometimes I tell them and they're just really terrible, or I just like cut them out for time because there's better stories in the episode.
Yeah.
And so then I kind of forget which ones I've already told. And so then I'm like, no, I think I cut that one out. So I think I can tell that one. So if I ever repeat stories, I'm sorry.
That's why.
Sorry, that's why. Well, thank you so much for taking time out of your Saturday to talk to me. And I hope you have a good Christmas party tonight.
Thank you. Thank you so much for having me on this podcast. This was so much fun.
Thank you, everyone, for listening. If you guys have any questions for me or questions for Liz, join our Facebook group, Antidote Stories in Medicine Podcast group. There's the Facebook page, but then also the Facebook group. So join the group and I'm going to be posting some stuff there and maybe Liz will join us and you can ask her some questions about being an ER nurse.
Definitely.
And then also check us out on Instagram, Antidotes Podcast. Twitter is Antidotes Pod. My Twitter is Christine the NP. And of course, thank you as always to Peter Hopkins, who does our custom intro music. Check him out at petesingsthings.com. You can always reach out to me at email as well at antidotespodcast@gmail.com. And please keep leaving those reviews. They really mean so much to me. They really help the podcast grow. And share these episodes. If you like an episode, send it to your friends. Please share the podcast. It really helps. So thank you guys so much. I will see you all next week.